You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for February 23rd, 2024. This week, reading Incidental coronary calcium on CT scans, exercise in women and men, PCI with or without imaging, and trial non-reporting. First is the issue of incidental coronary calcification. Now, doctors order a lot of non-contrasted CT scans for things like lung cancer screening, cancer surveillance, infections, and primary lung diseases. And the heart is always in these images. And coronary calcium appears as bright white signals. The question of late are whether a radiologist should note these calcifications, whether they should put the observation in the findings or impression of the report, and what, if any, impact there is on whether or not the incidental coronary calcification is noted on the report. A group of researchers from Johns Hopkins set out to study these questions. The Journal of the American College of Radiology published the findings. First author, Rubik Malik. They used a literature review strategy, a study of studies, if you will. They extracted data from 83 eligible studies, and they found wide-ranging results. For instance, the percentage of patients with ICAC, or incidental coronary artery calcium, ranged from 9% to 100%. 9% to 100%. 31 of the studies they reported on had associations between ICAC and cardiovascular and non-cardiovascular morbidity. The percentage of patients with incidental coronary calcium ranged from 20% in those screened for COVID-19 to 100% in patients with end-stage renal disease on dialysis. Two of these three publications mentioned the rate at which radiologists mentioned the presence or absence of CAC. It was only 31% and 44%. When radiologists mentioned incidental CAC, it was more often in the body of the report rather than the impression. 7 studies in their paper included percentage of subjects with incidental coronary calcium not on lipid-lowering therapy or antiplatelet therapy, and that also had a very wide range. 2 studies associated incidental coronary calcium with future cardiovascular events. The authors conclude that the data assembled support broad changes in our contemporary radiology practice. Quote, while uniform reporting will not generate a return on investment from the additional interpretation time or the cost of AI tools, it holds the potential to identify sources of patients with previously unknown coronary artery disease who can reduce their risk of morbidity and mortality through behavioral and medicine modifications. So my comments here. The authors note the substantial limits of the paper, especially the facts that A, no studies demonstrated a reduction in cardiac events or death resulting from incidental coronary artery calcium-related modifications in medical management, and B, no studies investigated a harm-benefit analysis of incidental coronary artery calcium readings or the downstream cost of additional testing and procedures. Yet despite these limitations, the authors also make very big conclusions, such as, quote, incidental coronary artery calcium deserves to be reported prominently in the impression of the report, and reporting is only a first step. Quote, performance improvement champions are encouraged to develop high reliability systems to ensure downstream care, end quote. I'm like, really? What evidence is there for downstream care? And what kind of downstream care? What if the patient is already on statins? What if the patient is 75 years old and coronary calcium is simply a part of aging? The authors go on to write, quote, and for patients who present to the emergency department and do not have primary care docs, radiologists should partner with emergency medicine physicians to capitalize on the opportunity to inform patients about the new diagnosis of preclinical atherosclerotic cardiovascular disease and arrange ambulatory care. Now, this statement too bothers me. Partnering with other doctors is fine, but they don't know it is a new diagnosis. And what does the whole diagnosis preclinical mean? I am not sure coronary artery calcium should be equated with atherosclerotic cardiovascular disease. I know proponents of CAC will disagree with this because they can cite observational studies showing that high CAC scores have similar rates of future events as those with established cardiovascular disease. But these are just associations. For instance, I had a neck x-ray recently and there was a small amount of calcium in my carotid. Do I now have carotid vascular disease? The author's final statement really bothers me. Quote, the field of radiology has the opportunity to bend the trajectory of cardiovascular disease by providing opportunistic screening on every non-cardiac chest CT performed, and given the potential to improve health and reduce expenditure, consideration should be given to incidental coronary calcium reporting as a quality metric for the CMS merit-based incentive payment system. My response is, what the heck? Bend the trajectory of cardiovascular disease? Look, the coronary artery calcium screening proponents freely admit that they can't do an RCT of coronary artery calcium screening because it would take hundreds of thousands of patients. And why is that? Because the effect size would be so small. So let's take that logic a little further. If you admit that you can't study regular CAC screening, why would the authors be so confident that incidental CAC noted on a scan done for other diseases would bend the trajectory of one of the leading causes of death? Have they ever heard of competing causes of death? This study is fine as a descriptive study. All they had to do was just say that incidental coronary calcium is common, it can be a new diagnosis in some patients, it might be seen in patients without other risk factors, and mentioning it in the impression associates with more statin use and lower LDLs. Then they could say, we are also very worried about disease expansion. We're worried about the potential harms that are iatrogenic and cost of downstream testing. We need much more work to determine the best reporting strategy because incidental coronary calcium in a 30-year-old with a spontaneous pneumothorax is a lot different from an 80-year-old with a known PCI who is already taking a statin. Disease creation, in my mind, should have a very high bar. Finally, I want to place some responsibility here on us. It's a bit unfair for us to say, call coronary artery calcium in this patient and not that patient. We shouldn't have to worry about what the radiologists are saying, whether there is coronary artery calcium or not. In a perfect world, patients in the medical system would be educated to pursue healthy living as a baseline, and clinicians would better understand chronic stable coronary disease. A positive CAC in a patient without cardiovascular symptoms ought not trigger any alarm in either clinicians or patients. The reaction ought to be, incidental CAC is a surrogate marker of future events like LDL and blood pressure and smoking, and at most, its presence would trigger a discussion about cardiovascular prevention. I've said this many times before, but patients differ widely on their goals. Some are minimizers, and any little modest increase in risk over the pooled cohort equation makes no difference. Other patients are maximizers, and they may be more willing to start statins and increase the dose of statins. And please, the final comment is CAC should never, ever, ever lead to a stress test in an asymptomatic person. Exercise. Regular listeners know how much I love exercise and physical activity as a therapy. Jack has published a potentially dangerous observational study on sex-based differences in exercise effects on cardiovascular health. It's dangerous because of the outsized conclusions based on very weak methods, and dangerous because a study like this is so flawed that it should not have been published in a prominent journal nor received such strong media attention. The research question was whether physical activity benefits differ by sex. Now, I guess that the authors felt that this was a good question because women lag behind males in exercise engagement. Maybe. Their methods used was to download data from the CDC website. This data is publicly available to anyone. It is survey data on self-reported physical activity. The data source also links to an outcome source. The authors then correlated reports of physical activity measures with all-cause and cardiovascular mortality over a 20-year period. The main findings were that regular leisure time physical activity compared with inactivity was associated with a 24% mortality reduction in women, but only a 15% mortality reduction in men. Their statistical program said that this was a statistically significant interaction. Their second main finding was that men reached their maximum survival benefit at a 19% reduction with 300 minutes per week of moderate to vigorous physical activity, whereas women reached their maximum survival benefit with 140 minutes per week, so less. Now, these sex-specific findings were similar for cardiovascular deaths as they were with all-cause death. Their discussion section uses many, many words to describe the explanations of these findings as well as the implications of these findings, and they concluded that women, compared with men, derived greater gains in all-cause and cardiovascular mortality risk reduction from equivalent doses of leisure time physical activity. Quote, these findings could enhance efforts to close the gender gap by motivating especially women to engage in any regular leisure time physical activity. This study has gained a massive altmetric score covered by 385 news sites, most that I scanned with headlines like, quote, health gains of exercise greater in women. My comments. My gosh, this is very disturbing. Let's just go to the author's discussion of the limitations, which did not make it into two of the news pieces that I read, nor, sadly, did any of these limitations make it into the editorial. The editorialist in JACC write that the study is, quote, well-designed and adds important information. Now, first, the authors tell us that all the physical activity data is self-reported from a survey that is likely far from a random sample in the first place. There was no use of objective data from accelerometers. Of course there is recall bias. A triathlete who's obsessed over their training program can recall their physical activity. That's about 0.1% of the regular population. Second, the authors write that, quote, given the observational design of the study, causal relationships cannot be presumed and results should be interpreted with caution. They say that unmeasured confounders could yet have influenced results, including differential reporting by male and female individuals, unassessed health status factors, and variations in physical activity engagement over time. So I would ask, where the heck was their caution then? Of course there are confounders in studies like this. People who report exercise at certain levels surely are different than people who do not. The authors, nor anyone really, has quantified the exact amount of exercise that is beneficial in either sex. In fact, I think this is a silly task because the Goldilocks amount of physical activity will vary so much per individual. I would also add to these critiques two other critiques. A, even if you believe the results, I don't, but the main figure shows overlapping confidence intervals. I don't care what their test for interaction says, I don't see enough precision to make these sorts of distinctions. B, the massive 24% reduction in death is simply not credible as an effect size. I have no idea how the peer reviewers, editors, and then editorialists just accept this extremely weak observational analysis to say there are actually implications about exercise. I think this is dangerous because it may encourage women to reduce their exercise who are exercising more. It's also dangerous because such weak methodology gains such outsized attention, perhaps because it gets in a prominent journal and it features a glowing editorial. I love exercise and physical activity. I prescribe it to the majority of my patients, men and women alike, and we can study aspects of it. But downloading a database from the CDC, running some stats, and making outsized conclusions is really problematic because it reduces trust in the adjudication of science. All right, third topic is PCI with or without imaging. Now, I don't do PCI, but I watch a lot of PCI because the EP lab is right next door to the cath lab, and I like to go in there and see what they're all doing. I've gathered that technical features of PCI are important, things like minimal stent area and freedom from major edge dissections. I can translate this into pacemaker language. There are right ways and wrong ways to do the procedure. The thing is that when you do an angiogram, it's just a two-dimensional view of the lumen. An intracoronary ultrasound catheter or optical coherence tomography device allows the doctor to actually see the inside of the vessel wall, imaging. Early studies have shown trends to benefit to image-guided PCI. Benefit as in lower cardiovascular outcomes, so real benefit. Now, 4 huge studies presented at the end of the year at ESC added even more data to this evidence base. The importance of these recent studies goes on beyond the larger numbers. These studies also involve the study of drug-eluting stents, and drug-eluting stents is an important thing to study because the complication rates versus bare metal stents may be lower. So an argument for not needing imaging is that we now have drug-eluting stents. So the studies are important because they add data with the newer technology. Dr. Greg Stone and colleagues have performed and published a vast meta-analysis on all this data comparing image-guided PCI to regular old angiography-guided PCI in their papers in The Lancet. This study combined with study-level data, 22 trials and more than 15,000 patients. Now, the trials varied quite a bit, but essentially this was image-guided PCI versus angiography-guided PCI. An image-guided PCI could be with ultrasound or it could be with the OCT. A handful of studies compared IVUS with OCT. The authors chose as their primary endpoint target lesion failure, or TLF. Now, that was a composite of cardiac death, target vessel MI, or target lesion revascularization. And the authors also did a risk of bias assessment, and nearly all studies were RCTs with a low risk of bias. The main results compared with angiography-guided PCI, image-guided PCI resulted in a 29% lower rate of target lesion failure. That's the composite primary. The hazard ratio was 0.71. The confidence intervals were very tight. That composite primary outcome had 3 components. The largest reduction came in the first, cardiac death. Here it was a 45% reduction in cardiac death, relative risk ratio 0.55, again with tight confidence intervals. The second component, the target vessel MI, was only reduced by 18%, relative risk 0.82, again with tight confidence intervals. The third component, target lesion revascularization, was reduced by 28%, the relative risk 0.72. Now, there were also a couple important secondary endpoints. For all-cause death, image-guided PCI resulted in a massive 48% reduction of death compared with angiography-guided PCI, relative risk 0.52, again with fairly tight confidence intervals. For stent thrombosis, image-guided PCI resulted in a 25% reduction compared with angiography-guided PCI, relative risk 0.75. And the authors also compared IVUS and OCT directly, and they found really no significant differences in any outcomes. So I take it that either IVUS or OCT are similar in their effectiveness versus angiography-guided PCI. Now, my comments. I want to start with a caveat, a curious finding, if you will. The primary endpoint and all of its components are positive, but the composite endpoint is driven mostly by lower cardiac death, and all-cause death is reduced by more than target vessel MI or target vessel revascularization. This is curious, right? Because if you posit that imaging improves outcomes by decreasing bad things at the site of the stent, you'd expect that target vessel issues would drive cardiac death, not the other way around. The reduction in cardiac death was 45%, and in target vessel MI was only 18%. And there were more than double the MI outcomes versus the cardiac death outcomes. Now, one explanation could be that imaging resulted in a marked reduction in stent thrombosis, which is a catastrophic thing and often leads to death. But here, the absolute numbers of stent thromboses was actually pretty low. The spread was about 30 stent thrombosis events and lower in the image-guided group. So what I cannot tell exactly is whether there is enough of these lower stent thromboses to drive the cardiac death signal. You know, though, when you go into the appendix, what you notice is that the number of the patients in each of the pooled arms is very large, thousands, but the number of events are actually quite low. So, my friend, Sanjay Kaul, Dr. Sanjay Kaul, Cedars-Sinai, once again helped me out, and he did some math. You should be following him on Twitter, by the way. He points out that the absolute risk differences are small. So these are the pooled effect sizes in the absolute risk differences. And for target vessel revascularization, 1.6%. Target vessel MI, 0.76%. All-cause mortality, only 0.68%. Cardiac mortality, 0.81%. And stent thrombosis, 0.61%. So they're all around 1% or lower. The number of trials that had significant differences in outcomes for target vessel revascularization, only 1 trial. Target lesion revascularization, only 2 trials. MI, 0. Stent thrombosis, 2. All-cause mortality, 0 trials. Cardiac death, only 1 trial, the Renovate complex PCI trial. Yet, in the main paper, on surface, the relative risks are impressive. They all line up, too. It looks like clear benefit. In the appendix, however, when you look at absolute numbers, the absolute risk differences are small. They might be significant, but small. And maybe that is why the image-guided PCI uptake is so low. I'm going to link to a study that found use of imaging is less than 20% out there in the real world. So, en masse, interventional cardiologists seem to be ignoring the conclusions of these studies and meta-analysis. Now, I'm going to go out on a limb here. The neutral observer looks at this data and thinks, come on, all the data is clear, use imaging. But maybe the experience of interventional cardiologists who are doing this every day. And one thing you all need to know about private practice is that since we're on service every day of our lives, we see the patients that we do procedures on. So maybe the interventional cardiologists doing the procedure don't see major issues. And perhaps inherently they feel these tiny absolute risk differences. Maybe they use imaging selectively for complex lesions. I know this is not a normal take for me, but something has to explain the extremely low uptake of image-guided PCI despite these major conclusions in the literature. Of course, there could be other factors in this tension between data and what people do. I've heard whispers that imaging is not well reimbursed and that it adds time to the procedure. And finally, before I leave this really excellent canvas for thinking, I want to contrast the imaging situation in interventional cardiology with my world of AF ablation. In the United States, intracardiac echo during AF ablation, basically imaging, is nearly universal in all procedures. Yet we have zero RCT level evidence that this add-on procedure reduces any outcomes. We know that intracardiac echo increases cost. We know that some of the best operators in Europe don't use it, but yet it is essentially standard of care here with zero data. Now, of course, it helps that until recently, ICE imaging in the United States was well reimbursed as an extra thing to do during AF ablation. But I'm sure that compensation had nothing to do with EP decision-making. Since I don't do PCI, I'd love to hear input on this tension between this excellent data and low acceptance, so please let me know. Okay, briefly, final topic, non-published trials. The Heart.org Medscape Cardiology has a very nice news piece on the matter of unpublished trials. This might seem like an esoteric topic, but it gets to the integrity of medical science. The news story by journalist Peter Russell covered a preprint from multiple authors who decided to look into the matter of whether the results of medical trials get reported in a timely fashion. Now, they chose to look specifically at trials from Nordic countries, but similar work has been done in many countries. As background, trials should be pre-registered before the trial begins. The authors of this preprint used the European Union Clinical Trials Registry or clinicaltrials.gov, and they looked at trials from 2016 to 2019. They had an exhaustive and systematic search for trial results. The total sample size they looked at was just over 2,000 trials. Of these, 77% reported any results during the follow-up period. So that's your first finding. 23% did not report any results. More than 1 in 5 trials had not reported results within a 2-year window of being completed. Just over half the trials reported within the 2-year window after completion, and only 2% had reported results within the 1 year from completion window. 1 year is the required window from authorities. Some interesting details. Denmark was the largest contributor among the Nordic centers. Large trials versus small trials were more likely to be reported at all and within the 2 years of completion. And medicinal product trials versus non-medicinal product trials were more likely to have summary results. And the authors found no differences per multi-center status or industry-sponsored status. The authors summarized their findings by writing that only half of trials led by Nordic medical universities were reported in adherences to WHO recommendations. Timely results were even more rare at 2%. Among EU clinical trial registrations for which the practice is now mandatory, the proportion was only 7%. For 22% of trials planned to involve more than 83,000 participants, no results could be located regardless of the time limit. And here is a big one. Contrary to established recommendations, almost half of the registrations were made retrospectively, which of course limits their usefulness. So my brief comments on this, the authors stress that they are not picking on Nordic countries. This has also been reported in Germany, and these Nordic results were similar. Canada has done better, but still with room for improvement. A cited paper from Canada found 59% of trials were pre-registered prospectively and 39% had reported results. Poland has had especially good numbers of reported trials. We should first set out some of the limitations of this paper. As the authors do state clearly, some of the trials may have been listed as completed in clinicaltrials.gov, but never really finalized. I mean, sometimes people put trial ideas up on the clinical trial site just to sort of patent their ideas, so to speak. Now, this may be especially true for smaller trials. However, the best argument that their findings are true is that industry-sponsored trials had equally low reporting as seen in the appendix figure 9. So, my summary. As a reader of medical science, I had no really idea that massive amounts of data remain unpublished. Now, what's in that trove of data? We don't know. One example that comes to mind is the rosiglitazone story. So rosiglitazone had a signal of increased cardiac events in their seminal trial, but it not quite reached statistical significance. Then, Dr. Steve Nissen from the Cleveland Clinic obtained oodles of unpublished trial results. And when they combined that data, meta-analyzed that data from the unpublished results with the published results, they found much stronger signals of cardiac events, and now we know that there's a cardiac signal with rosiglitazone. Of course, not every story of unpublished data will be so dramatic, but the point here is twofold. One, patients have been experimented on, and it is both moral and ethical to report results. And secondly, the scientific enterprise is diminished without all of the published data. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time to give us a rating, write us a review. If you have something to say, go to the heart.org Medscape website. There's a place to comment. Leave me a comment. Teach me something. Until next week, this is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.